Welcome to the deep dive. We know you need to be well-informed and fast. So we've done the legwork, we've gone through the sources, and today we are diving into a really monumental piece of clinical research. I think this one is going to fundamentally rewire how you think about treating some very specific high-risk heart conditions.
It really is.
We're analyzing the results of the AR study. This is a massive multi-center trial, and the focus is on transcatheter aortic valve intervention, TAVI, for short.
Right.
But, and this is the key, it's TAVI being used for a very different purpose with a brand new tool, the Trilogy valve, to treat something called symptomatic native aortic regurgitation, or AR.
And that distinction is, well, it's everything. For anyone who might not be deep in this field, TAVI has been revolutionary, absolutely.
Yeah.
But it was built to solve a totally different problem.
Aortic stenosis.
Exactly. That's it. Where the valve gets stiff, calcified. You can almost think of those valves as a rock. They're sturdy. They give a standard TVI device something firm to grip onto.
But aortic regurgitation, the AR we're talking about today, that's basically the opposite problem, isn't it? It's not stiff, it's leaky.
It's completely the opposite. The valve leaflets are floppy, they don't seal properly, and blood just washes backward into the heart. It's a soft, non-calcified environment.
So the old tools just don't work.
Not well. I mean, if the standard TVI device is like an expanding bolt made to grip rock, using it for native AR is like trying to anchor that same bolt into, say, wet clay.
It's just going to slip.
It's going to slip or migrate or just fail to create a seal. So the need for a dedicated, purpose-built platform like this Trilogy valve is precisely why this research had to happen.
And this study, published in the Lancet, is really setting a new benchmark. So our mission here is to pull out the most important safety and effectiveness findings and really understand what this tech means for a very vulnerable group of patients.
Let's get into it.
Okay, so let's start with who we're talking about, the patient population. Who exactly was this new valve platform designed for?
The study was laser-focused on individuals who were classified as being at high surgical risk.
So these aren't your typical surgery candidates?
No, not at all. These are patients where traditional open-heart surgery, cracking the chest open, carries a severe, even life-threatening risk.
Right.
And they were suffering. They had symptomatic, moderate to severe aortic regurgitation.
Meaning the leak in their heart was actively causing major problems.
Yes. Things like severe shortness of breath, signs of heart failure. It was impacting their daily lives in a big way.
That context is so important. It really frames the significance of any success here because if you're that high risk, your options are already incredibly limited.
They are. And the study structure itself, it really speaks to how robust the data was intended to be.
It wasn't just a quick look.
Oh, no. The LANCET study was set up as a prospective, multi-center, single-arm investigational device exemption study.
Okay, that's a mouthful. Let's break that down.
It is. But really, it's just medical jargon for a very carefully planned, detailed investigation of a new device across 30 major centers in the USA. This kind of setup is designed to give you data that you can really trust.
And the scope was huge. They screened, over 1,300 patients to find the right group?
That's right. And they ultimately enrolled 700 patients. So you have a huge pool of data coming from this.
What did that group look like demographically?
It was a very typical high-risk profile. The median age was 79 years old, so mostly elderly patients. And it was split pretty evenly, about 46% female, 54% male.
And it's a long-term study, too, running from 2018 and not even officially finished until 2025.
That ensures we get that crucial long-term follow-up data baked right in.
So before we get to the one-year outcomes, let's just cover the basics. In the procedure itself, in the cath lab, did the device actually work? Was it technically successful?
It was. And that's the first big hurdle you have to clear. Procedural feasibility was, it was established with flying colors.
What was the number?
Technical success. So the valve being placed correctly and working right away was achieved in 664 of the patients. That's a 95% success rate. For a new device in a high-risk population, that's a very strong start.
Okay, this is where it gets really interesting for me. The study set this incredibly high bar for what success even meant. They used these two co-primary endpoints for safety and effectiveness.
Yes, they really challenged themselves on both sides of the coin. So first, let's look at the 30-day safety goal. This was what's called a non-inferiority test.
Meaning it couldn't be worse than the alternative?
Exactly. It just means the Trilogy procedure couldn't be statistically, significantly worse than what we already know happens with other high-risk treatments. They measured a whole composite of major adverse events, or MAEs.
And they tested that against a performance goal of 40.5%. Where does a number like that come from?
It's derived from the literature. They looked at existing data for this high-risk group and saw that the baseline risk for a collection of bad outcomes was around 30%. They added a statistical margin, and that gave them their number. So the valve had to prove it could beat a 40.5% complication rate in the first month.
Okay, so that's safety. Then you have the second goal, which feels even more ambitious, the 1-year effectiveness goal.
And that was a superiority test. This is where they had to prove the device was definitively better, and they focused on one thing: all-cause mortality.
And the performance goal here was 25.0%.
25.0%.
Let's just pause on that number for a second, because for anyone listening, 25% might just sound like a statistic. What does that truly represent for this specific group of patients?
You're right to pause there. It's absolutely crucial.
Mm-hmm.
That 25% expected mortality rate at 1 year wasn't pulled from thin air. It was based on the grim clinical reality for these high-risk, often elderly patients with severe AR who they don't have other good options.
So you're saying 1 in 4 of these people, under normal circumstances, wouldn't survive a year.
That's the harsh reality. 1 in 4 would not see their next birthday. That is the incredibly high bar this Trilogy valve had to clear. It had to do better than that.
And to really understand that safety bar, let's just list what was in that major adverse events composite. It was comprehensive.
It was. It included all-cause death, stroke, life-threatening bleeding, kidney injury, vascular complications.
Needing other procedures, getting a new pacemaker, we'll come back to that. And critically, still having a significant leak after the procedure.
Right. It was basically the everything that could go wrong checklist.
So with that tough checklist, how did the Trilogy valve actually do against that 40.5% safety threshold?
The results were, frankly, outstanding. The 30-day safety endpoint, that whole composite, only occurred in 24.0% of patients.
24%, so well under the 40.5% goal.
Miles under it. I mean, the statistical value, the p-value, was less than 0.0001.
Mm-hmm.
That's a scientific way of saying we didn't just meet the safety standard, we blew the ceiling off it. The confidence in this safety profile is just absolute.
Okay, but let's dig into the nuance within that 24%, because that's where you find the trade-offs. For the most severe events, death was just 1.6% and stroke was 1.7%. For this population, those are remarkably low numbers.
They are excellent short-term survival numbers. But you have to look at the elephant in the room that often comes with these transcatheter valve procedures.
A pacemaker rate.
A new pacemaker rate. And it happened in 127 patients, which is 21.6% of the group that was evaluated for it.
Okay, let's sit with that. 21.6% is, well, it's more than 1 in 5 patients needing a pacemaker. Should that be a cause for concern, or is this just a known cost of doing business here?
That is the critical question, and it is a high rate. No clinician ignores that. But you have to see it through the lens of what problem you're solving.
All right.
The Trilogy valve has to anchor in that soft, non-calcified tissue we talked about. To get a good seal, it sometimes has to exert pressure near the heart's own electrical system. So the trade-off is often a minor electrical disruption needing a pacemaker versus, the catastrophic failure of that leaky valve.
And when you look at how well it fixed the primary problem, the leak itself, the results were nearly perfect.
Exactly. That's the other side of the trade-off. If you look at its core function, controlling the regurgitation, the success was just overwhelming. Only 0.5% of patients had a moderate leak left over. And more importantly, severe AR was seen in 0 patients. None.
Wow. So it completely eliminated the most dangerous leaks.
It did exactly what it was designed to do mechanically. So yes, the pacemaker is a known and manageable trade-off for completely solving the AR problem.
Okay, so let's move past that first month and look at the real prize. That 1-year mortality goal. The expectation was that 25% of this group would not survive.
And this, for me, is the most profound finding of the entire study.
Yeah.
That expected 25% mortality rate was it was shattered. The actual all-cause mortality at 1 year was only 7.7%.
7.7%.
Yes.
That is a massive difference. Going from an expected death rate of 1 in 4 to, less than 1 in 13? It's hard to even process the human impact of a jump like that.
It grounds the statistics, doesn't it? When you think about the actual number of people, of families affected, dozens of people who, under the previous standard of care, would likely have died are now alive and feeling better.
And the statistical significance was there, I assume?
Oh, absolutely. The superiority test was met with ease. And they provided even longer-term data, which confirms this wasn't just some short-term fluke.
Right. They had data out to 2 years.
Correct. All-cause mortality at 2 years was still relatively low. It only climbed to 13.3%. And the median follow-up was over a year. So we have good, solid, sustained data here. It suggests the valve is durable.
So let's synthesize this. Beyond just the survival numbers, what was actually happening inside the patient's heart? What did TAVI with this dedicated Trilogy platform really achieve?
This is where the story gets even more fascinating. The study confirms you get excellent mechanical results, so a
Mm.
huge reduction in the leak and really favorable valve hemodynamics, meaning blood flows through the new valve beautifully. But the truly vital part for long-term survival is something they call positive myocardial remodeling.
Let's unpack that term. Why does myocardial remodeling matter so much to a patient?
So think of it this way. Aortic regurgitation forces the heart to pump the same blood twice. It's constantly overworked. It's like you're cycling uphill with the brakes permanently on.
It's inefficient and exhausting.
Totally.
Mm.
And over time, the heart muscle, the myocardium, it stretches, it thickens, it gets tired, it remodels itself into a bigger, less efficient shape just to cope.
I see.
Positive remodeling means that because the Trilogy valve fixed the leak, that huge strain on the heart muscle is finally released. The heart actually starts to shrink back towards a healthier, more normal size and shape.
So the heart itself is healing.
It's healing.
Yeah.
And that physiological benefit is a huge, often unstated win. It dramatically reduces the long-term risk of heart failure, which is the ultimate killer in these cases.
And this all connects directly back to the listener, to the patient's actual life. Because those clinical wins, the low mortality, the better blood flow, the heart recovering, they translated directly into.
Improvements in functional status and quality of life. And those gains were sustained for up to 2 years.
So this isn't just about numbers on a page, it's about people being able to live their lives again.
Exactly. It means they aren't confined to a chair, they have fewer symptoms, they can do more, and their overall quality of life is just significantly better. That's the ultimate validation of a device like this. It's feasible, it's effective, and it delivers deep, meaningful, long-term benefits to people who had very few good options before.
So to wrap up the analysis, the A.I.O data gives really strong support for TAVI with a dedicated device like Trilogy. It's a feasible and highly effective treatment for these selected high-risk patients.
It really is. They met that high safety bar and then just overwhelmingly proved their superiority when it came to effectiveness.
This dedicated technology really does feel like a game changer for a condition that was, frankly, underserved by devices designed for a completely different problem.
They've successfully adapted TAVI for a new frontier. And that, I think, leaves us with a final provocative thought to consider, building on everything we just dissected.
Why?
We know this ALIGN-R cohort was made up entirely of high surgical risk patients. But given the incredible mortality reduction, we saw 7.7% at 1 year versus an expected 25%, and the huge quality of life gains, well, you have to ask the next question.
Where does this technology go from here?
Precisely. How might the medical definition of high risk evolve? If these dedicated TAVI platforms become the standard of care and keep showing this level of safety and effectiveness, will researchers start to move this therapy into intermediate risk or maybe even lower risk patients down the line?
Because expanding it would mean bringing these same life-altering benefits to an even broader population.
And that's the next frontier this data opens up for heart care.
A great question to sit with as this technology becomes more widely adopted. Thank you for joining us on the Deep Dive. We'll see you next time.